the approach that we've had for healthcare reform in general has been, first of all, to look at what was done in the past, what didn't work, and why it didn't work. And a very good example was the general health insurance. And when we look, and we went back and we read every report, looked at every parliament meeting, and what is the bottleneck? You're trying to do too much with one piece of legislation. That's the essence of what went wrong with GHI. There are aspects of it that some said, we're good with this, but we're not good at that. But when you make far-reaching amendments in Parliament, it would have to go back through the process. So it gets stuck. So our approach has been, no, let us take all of the different elements on legal reforms that are needed and bring them to Parliament, and what can be changed on a ministerial level by means of policy, national decrees, and so on, we've done. So for example, one of the big problems that we've had is the amount of finance coming in and how many people are paying into the SZV. We've raised the SZV limit and brought that legislation to Parliament. With regards to the BIG, yes, I agree with both colleagues that we need another solution to that, and the idea would be kind of like, originally, some people were saying, well, create our own BIG. I think that's a long-term plan, but the people need solutions right away, especially with this referral situation. So what we're doing is, you look at your existing law, and it is much easier to make amendments to your existing law and then incorporate these changes. And a simple amendment that we found is to actually allow an article to be added that allows the minister to be able, by ministerial regulation, to create, just what was said, our own sort of evaluation process on the doctors that can work here. And one of the things that can form part of that evaluation process is what was mentioned and what many people say. You have people that we're sending to Colombia, to Panama, and so on, and they are treating our patients. So for example, that can be part of your qualification process. Have you worked at such a hospital in so many years? Have you been taking care of St. Maarten patients? Not saying that's the only qualification, but that can be part of it. That amendment is already on its way to Parliament, and that will be a solution that will be much more short-term and something that can help us get more qualified personnel as much as possible, because how that ties into referrals, the more qualified healthcare people can get in St. Maarten, the less people we have to send away.
Now, based on the amendment, let me just chime in. So it would be the minister's preview to then make this registration. Wouldn't that be dangerous for a minister to have that?
It wouldn't work that. No, it wouldn't work that way. The law will create the basis. So all of the guidelines will be approved by Parliament. But the specifics, for example, of where would the registry be held, what the process would be to apply, that of course you allow those nuances by ministerial regulation, but the high level of what the framework of your BIC should be would be in the legislation. So you never in legislation delegate, you delegate more procedural things to the government, but the nuances and the details of what can and cannot happen and should not happen, you do that at the higher level.